test response of low-level exposure to ambient air pollution and cause-specific mortality in 3 Canadian longitudinal cohorts. Anders completed his Bachelor's of Science in Geography at the University of Victoria, a Master's in Community Health Science at the University of Northern British Columbia, and his PhD in Interdisciplinary Studies back at the University of Victoria in 2016. His research interests predominantly focus on the spatial and environmental epidemiology of chronic and reproductive health and the interaction between social, genetic, and environmental risk factors. Anders is an instructor for Pop Data BC with their Population Health Data Analysis Certificate Program and will be teaching a course for SPPH next term. That is the SPPH 522 Topics in Environmental Health. So without further ado, please join me in welcoming Anders.
Great, thank you. How are my levels? Good? Good, okay. Well, I want to thank the folks who organized the OEH seminars. So I'd like to thank Hind and Joseph for doing all the work that they do for these weekly seminars and everybody else that puts these on. I would also like to acknowledge the traditional territory of the Musqueam First Nation, of which the UC sits on. And yeah, so I'm a new postdoc here. I started in February, and so I'm going to give an introduction of a little overview of what the project that I'm working on, which is a great acronym name of MAPLE. And so it's mortality due to air pollution at low levels of exposure. Our team is pan-Canadian, and so we have people from all across Canada doing work, and then one person, Perry Heisted at Oregon State University. Yeah, a great group of people to be working with. And so just a little brief overview of the presentation outline. I'm going to be doing, give the project objectives, some overview of the exposure assessment, the summary of the analytical plans, a little bit of the published results so far, the indirect adjustment method, so that's part of the project that I'm working on currently right now, and then if we have, hopefully all questions for comments, time for comments and questions. So it's great when in the media they drop a great, current story in your lap for a talk. So all in the news today were this Lancet study that came out, or Lancet statement that came out, and they were talking about pollution in general, but a lot of it is derived from air pollution, and they 9 million deaths annually and 4.6 trillion loss in monetary losses every year due to exposure to deaths due to environmental pollutants. Often, this affects wealthy nations as well as the whole spectrum of nations all the way to poorer nations, and often even within those different countries, you have an environmental justice issue where those who are more disadvantaged often bear the brunt of the exposure and the costs. And also to show, in order to give a little bit more motivation for policy, is that clean air policies do work. There's the Clean Air Act, and this is U.S. stats. So the Clean Air Act that was passed in 1970 has shown a 30-to-1 ratio in benefit. So it's been, I think it was like $1.5 trillion in benefit in benefit to economy and health versus a 65 million cumulative cost of those policies that have been put in place. And then similarly, there's been a cumulative gain of 6 trillion earned from having a more intelligent, better workforce that are healthier and non-exposed, having non-exposed children when they started removing lead out of gasoline. So there's 3 objectives to the MAPLE project. The first one is to apply novel individual level estimates of PM2.5 exposure to a large population-based, several large population-based cohorts. Canada in general is a fairly good environment for looking at low air pollution exposures, because for the most part, most of Canada has below 12 micrograms per cubic meter in PM concentrations. The second objective is to characterize the relationship between PM 2.5 exposure with all-cause and cause-specific mortality. And so this includes cardiovascular disease, diabetes, ischemic heart disease, respiratory diseases such as chronic obstructive pulmonary disease, and pneumonia, and as well as lung cancer. And then the third objective is to characterize the shape of the concentration mortality association. So look at the dose response curve at these low exposure levels. It's noted in that Lancet study that there is no really good evidence on what the low dose, what that dose response looks like at the low levels. And so we have a little bit of data presenting. I have a little bit of data presenting that today. So move on to the exposure assessment overview. So we have quite a big challenges in Canada when we're doing exposure assessments. Canada, one, is a very large country, but has a very sparse network of fixed site stations, and most of them reside in big cities and along the 49th parallel. So we have huge gaps between the major cities and where other Canadians live, such as in rural and remote locations. So all these other non-monitored areas need to be modeled. The other challenge is you need exposure data with temporal agreement with the cohort. So we have a cohort that starts going back to 1991. I'll be talking a lot about a 2001 cohort. So, and of course, we want long-term exposures. So what were the exposures prior to 1991? So we need to go back, we want to go back at least to 1981. And so we need to have backcast air pollution estimates down back to 1981 levels. And then, of course, the other challenge is that people move over these 20 years of follow-up, and so we need ways to follow them and where they are on an annual basis. So the exposure assessment objective, one, we want to apply, currently there's a 10-kilometer resolution with the satellite-based PM across North America. We are developing a 1-kilometer resolution for this. And then the folks, so it's Randall Martin and Aaron Von Donkler are kind of leading this part of this project, and they are doing a bunch of nice work on using geophysical and statistical methods to further refine these PM 2.5 estimates. And then we want to improve and evaluate this PM model. And then we want to create annual estimates and backcast it all the way at least to 1998 and eventually all the way back to 1981. And then scale the 1-kilometer surface back in time. So there's a little cartoon of the steps. So one, we create this basic surface at a 1-kilometer grid. Then we are refining these estimates. We evaluate and improve the methods using some different methods on the ground monitoring. And then we create these annual and historical services going back in time. And so here is a nice map of what the PM levels look like across North America, and we will be expanding these to these 5 sites. So this is happening right now. They're collecting data, we're getting measurements, and everything's supposed to be tip-top and going tickety-boo. And here is a map of Canada, of course, showing some of the exposure levels in some of the bigger cities. And this map is using the 10-kilometer resolution. And so I'll show you a little bit of the difference when you go from 10-kilometer resolution here, and then when you go to a 1-kilometer resolution, you get a lot nicer, finer resolution and less mismeasurement error. So now once we have the surface for every single year going back in time, we need to now assign this exposure to the cohort subjects. So I'll go into a little explanation of the residential history and what these cohorts are in in a few slides, but right now we have a cohort of people who filled out the long-form census in 1991 as well as in 2001. And we have, so when they report their 6-digit postal code, and then we're able to track them based on their tax files that they reported every year. And so they're followed for either 20 or 10 years in the case of the 2001 census, and we can track them, or Stats Canada has tracked them based on their annual filing of income tax. So once you have the postal code, you can use the postal code conversion file, the PCCF Plus, and this gives you geographic coordinates as well as other geographic information such as the dissemination area, census divisions, as well as the type or the size of the city that these people live in, so rural towns, small towns, medium-sized cities, and large cities. And so then you have these point estimates of where people live for every year, and then you can assign their exposures. And what we're doing is we want to look at these lag periods of time before an event occurred, so event being a death occurred. So here we want to, in this case, say a death occurred in 2006. What we actually want to estimate are the 3 prior years prior for that individual. And so you go back in time using this 1-year lag method, looking at a 3-year moving average window. And what we'll end up doing is testing this lag window. So we've done 7-year lags in the past. We'll probably do a 10-year lag window and then a 20-year lag period of what previous exposures were. So to summarize, we end up with this well-refined evaluated exposure data that is spatially and temporally coinciding with our follow-up periods, including our annual exposure histories for subjects across the entire country. So just now for the analytical plan overview. So this will give an overview of how these cohorts were constructed. And so the first cohort we have is called the CanCheck. It's called the Canadian Census Health and Environment Cohort. Currently there are 2 that are available. You can access this data if you have a project that's funded. You can go and access this data in the research data centers, these RDCs, which are located often in libraries and universities across the country. Currently I'm using the 2001 CanCheck, and you get a long-form census, people who filled out the long-form census in that year, and it's roughly about 20% of the population. You have certain exclusions, so people who are under 19 years of age, who live overseas or in institutions are excluded. And then so you have this in-scope population, and then using income tax records, they use this deterministic and probabilistic linkage method, which approximately linked about 80% of the long-form census respondents. And then from there, we linked the mortality database, hospital death registries, and this was able to link about 99% of the respondents of the 2001 long-form census. And then that's how you get, so the reference is down below. And this was also done for the 1991 long-form census respondents. So the postal code imputation, this was a whole other, all this was done years ago. As you can see, some of these references are for, well, this one's this year, but so this shows how the postal code imputation occurred. So in this top case, if the person was missing a postal code or they didn't file their taxes for a single year in 2002, but they did file their taxes for 2001 and 2003, and it's the same data, it's the same postal code, you can impute this missing postal code as the same one, and this imputed about 95% of the cases. And then in other cases, you have maybe a lag of 3 years of missing postal codes. This was then, what they inferred was that you could impute the one after on either side, but then the one in between may be missing. And this was about 80%. And then you can do common characters. So if you had a 1 in this third case, K1A, A1A, and then missing, and then K1A to B2, you can infer that these first 3 digits may be similar. And so at least you can get a forward sortation area for where those people lived. And then in the case where you have it's missing right at the baseline year, so in 2001, if they're missing, and then there's not really any positive way to know where they live. They could have been out of the country, so it's not imputed, so it goes in as missing. And so when validation was done, it looked like it was about 4.2% of the imputed postal codes had a greater difference of 0.1 microgram per cubic meter. So the imputed postal codes who were imputed did not see a very great difference in their PM exposures. Okay. And so this is what some of the cohorts look like. Like I said, we have the 1991 census cohort, so it goes from 1991, all follows people all the way up to 2001. And then currently this is almost available. They're building a 1996 can check with 3.5 million subjects. The 2001 census with 3.5 million people. And then we also have the CCHS. So this 2001 to 2008 pooled CCHS, the Canadian Community Health Survey. And this one has also been linked to tax records and mortality records, and follows people for up to 2008, and it's about 390,000 individuals. And this one is, the CCHS mortality data set is a really interesting data set because you can get lifestyle, behaviors, and other types of data that aren't available with the census data. So speaking of variables, these are some of the variables that we will be using in the study. Like I said, the can check is a census-based cohort. So we end up with some of these standard variables at baseline, so age, sex, ethnicity, immigration, Aboriginal identity, marital status, income quintile, education, employment status, but you don't get behavioral or lifestyle factors such as alcohol consumption, smoking, fruit and vegetable intake, physical activity, or body mass index. So for that, you need to refer to a community health survey, which does have these types of data, as well as a whole bunch of other types of data, such as that you may be interested in looking at health behaviors and health outcomes. We also have contextual. We want to look at the contextual level, contextual variables or area-based variables for these individuals. So what most of the papers we've done in the past use these census-derived proportions based on some geography. So either a dissemination area, or in this case, or a census division, use the percentage of people who are unemployed or are in low-income brackets, recent immigrants, and a percentage of low-income people in certain neighborhoods. What I'll be using and what we're going to be planning on using for most of the studies from now on is a deprivation index, and we're going to be using this Canadian Marginalization Index, also called CanMarg, and it had 4 factors, and it uses census and census community CCHS data in order to create these factors that are continuous scores and quintiles at the dissemination area, as well as the census tract, the CT level of geography. And so these things include residential instability, material deprivation, dependency, and ethnic concentration. And then regional variables include the population center size, so the size of the city, whether it's rural or small town or a large city, as well as airsheds. And if you ask, wondering what airsheds look like, these are the airsheds, in Canada. There's about 6 and these kind of approximate roughly where the kind of major weather patterns are occurring in wind directions and speeds. So then overall, once you put this all together, you end up with an annual analytical cohort that has these either TANCHEC or the CCHS cohort with linked individual level covariates as well as mortality data, when they died and what they died from in terms of non-accidental deaths. You end up with, we have contextual variables as well as air pollution data. So I've mainly been talking about PM 2.5, but we also will be collecting data on, have data estimated, modeled for ozone as well as nitrogen dioxide, and then we'll be looking potentially also at redox potential, which is the oxidative potential measured. So the statistical overview. So most of what we will be doing, the types of statistical models we'll be running are these Cox proportional hazard survival models or slight variations of this method. And one of those variations are what we see these shapes are. So we want to look at nonlinear, really interested in what the nonlinear association is between air pollution and mortality is. And so you get what these, what's called the shape-constrained health impact functions, or these shift curves. And they can look like the figure that's in your A in the top left is pretty much a linear association, but then you can have any variation of these sigmoidal types of shapes. And so what these do, are that you run these models, running different variations of these. You weight them based on the probability of what that shape is. You combine them all together, and then you might end up with an estimated shape of what that dose response looks like. Our colleague at Health Canada, Rick Burnett's doing most of this work, or is the brain behind all of this. So we have about 10 projects that we want to be doing with this project. We have our first paper came out earlier this year, which uses the 2001 CanCheck. So this was sort of our base paper that we're going to be referencing a lot throughout this project. It kind of explains the cohorts, it explains all that linkage that I just went through, and as well as the exposure assessment methods. And so this included some of the regional population center size strata variables, as well as these shift curves were assessed, and I'll go through some of these results in a few slides. Another paper that is nearing submission is this other great source we have. So we have multiple mentions of death. So sometimes you have a mention on the death certificate that's such as diabetes or pneumonia. They weren't necessarily the primary cause of the death, but they're maybe an underlying cause. So we have a paper coming out focusing on diabetes and what its potential role is underlying some of mainly cardiovascular and cerebral vascular deaths, and it seems to play those who have diabetes could be potentially at a much higher increased vulnerability to mortality. The indirect adjustment for lifestyle and behavioral covariates, I'll talk about this in a little bit more later on. This is what I'm working on. And then we're going to be doing some sensitivity analysis, so we're going to look at those exposure time windows, those lag windows, as well as different types of spatial buffer sizes as well around. So looking at we're going to be comparing that 10-kilometer grid versus that 1-kilometer resolution that we're producing. More sensitivity analyses, and we're looking at some of the oxidant gases and oxidative potential. Working on a data set that looks at workplace locations, so not just residential locations, but also commuting routes and workplace where people worked as well. Then we're going to expand the CCHS mortality. So right now we have 2001 to 2008 for the CCHS mortality cohort. We're going to expand that to at least to 2011 to coincide with all the rest of the papers that the rest of the project that we're working on. And then for the grand finale, we hope to do this combined analysis, this stacked analysis, where we put all these CanCheck models, data sets together, producing a data set of 10 million respondents, following them for 20 years, and which will allow us to look at a whole bunch of subgroups, restrict the analysis to only people who have only been exposed to, say, less than 5 micrograms per cubic meter, or 10, or look at specific subgroups such as recent immigrants who tend to be healthier than regular Canadians. So we want to look at what maybe potentially how they fare as well, and then look at in-depth analysis of the concentration in some of these dose response curves. So here's the results from that paper that was published earlier this year. We have non-accidental deaths, so this includes all these chronic disease outcomes, chronic disease deaths that we have. There's 233,000 of them. And we have the 3 levels of, what did I do? Oh, wrong way. We have 3 levels of our adjustment. So we adjust for individual level covariates, and then we adjusted for individual plus the contextual level covariates, and then we have this third set of models that's stratified by the population size as well as the airshed in order to compare. And you do this in order to sort of adjust for intercity differences and interregional differences between the population. And so we see that for all non-accidental deaths, we see at the end with a fully adjusted model, we have about an 18% increase risk in mortality with, and this is with a 10 microgram per cubic meter increase in PM2.5. And then breaking this down into cause-specific mortality, we have, so cardiovascular disease, we have an overall 25% increase in mortality, and then you can break this down, CVD plus diabetes, or include diabetes with that, and that's pretty much the same, 27% increase. And then different outcomes, ischemic heart disease, have a 36% increase in mortality. And then 2 other outcomes, respiratory disease, this includes pneumonia and COPD, after adjustment, we end up with a 22% increase in mortality risk, and then lung cancer is 16%. So we also looked at these curves as well, and so I've divided them, I've divided them up. So these top 2 correspond to A and B. The second row corresponds to C and D. Third row, E and F, G and H are on the bottom. And these are what these curves can look like. You get these what's called supralinear curves. So what you end up with is that these curves are more pronounced. You have a greater dose response at these low levels of exposure, and then the effect tends to taper off. And of course, as you get less and less respondents in this area, you also, the graded shade area is the 95% confidence intervals, so your imprecision also increases. So, this is sort of good and bad news in a way, because at least if these shapes if the association was linear, if you were exposed to levels of, say, PM2.5 that we were exposed to this summer and with some of the wildfires, we would all be dropping dead pretty quickly probably. And so you see these shapes that taper off quite a bit, and some that are just maybe not even significant in case of pneumonia. Hard to say. So now moving on to the indirect adjustment. So these results were done, but they were not adjusted for smoking or alcohol intake or other sort of mortality risk factors. So these census cohorts are great because they have lots of individual level covariates, but they do not include other risk factors such as smoking, obesity, diet, exercise, and alcohol consumption. So what you need to do is assess this marginal confounding effect of what these behavioral risk factors have on the PM 2.5 mortality association after controlling for all these known individual level covariates that are in both the data set or in both data sets. So what we end up using is the CCHS data, which does have these behavioral covariates, and you end up producing a design matrix that kind of matches them up. And the nice thing about this is that what this method does is not attempting to find the best prediction model, but you do require that the health survey that you're using and the cohort that you're comparing against, they need to be representative. And so what you end up with is when you have a census cohort that is mandatory, and then you get a health survey that's non-mandatory, you have difference in the type of population who answer these types of questions. And so you also have slight geographic differences in the respondents and where they're at. So do they have the same do they have the same exposure profiles divided by different areas, as well as by these different outcomes? So are males and females in the can check, do they have the same exposure profile as males and females who answered in the CCHS? Same with, say, people who are, say, married common law versus single or widowed and divorced. Do they have the same exposure profiles in the can check versus the CCHS? So all these need to be, all this needs to be assessed and checked out. So this is what I'm going through right now in the RDC. I'm having a great time doing it. Spending a lot of days. Most of the summer was in the basement of the library, but it's not so bad now when it's raining so much. And so, yeah, so here is, so after it's all said and done, I won't go too much into this, but you end up with, so this is the hazard ratio, so this ends up being your main adjusted hazard ratio, and this is the hazard ratio, so you're dividing the unadjusted hazard ratio, and you're dividing by this hazard ratio that you get from using either the CCHS, or you can use these rates that are gained from the literature. And you have two different types of matrices that you're developing. One uses all the known individual level risk factors, so these are the factors that are in both the can check as well as the CCHS, such as the age, sex, marital status, etc. And then the missing covariates that are in the CCHS, so it includes smoking, alcohol consumption, and so forth. So what happens in the end? So we need to do a bunch of sensitivity analyses to compare to make sure that these models are running properly. You do these bias is dependent on the magnitude of the missing risk factors of the HR of the hazard ratio, as well as the correlation between the missing factors and the available risk factors. So what you do is run a gold, sort of kind of test it using this gold standard. So you use factors such as education and income, which are in both the data sets, take them out of one, run these indirect adjustments, and then test it versus when they're in the actual model, and you can see what these biases are. And so these are used mainly in order to, one, calibrate the model, or calibrate to see what how the method is working and see if it's working properly. And then you can use it, rerun it using all the unknown covariates. And so I've talked about this already. This is to assess the representation of the two cohorts. So you want to have the similar ages, non-immigrants for this specific right now. These time periods need to match up. So we're looking at base 2001 versus 2001. We want to make sure, we want to look at the location of the subject, so assess the non-matching postal codes between the two cohorts, and then compare the correlations between the exposure and the risk factors in the cohort and the survey. And then, so while the correlation gives the direction, we really need to run the analysis in order to know what the magnitudes are for the adjustment. And so these are old curves, but this is what you might have with the can check. And then when you run the similar model, this is what you end up when you start doing some adjustments for individual these behaviorals. So we want to know what curve is the true curve, or probably something in between. And this will be, and hopefully the goal is to have this paper out by the end of, or a good working copy by the end of the year, or January kind of thing. So I got lots of work to do. So I'll take any questions you have.
Thank you, Anders, very much for this really good presentation, tackling some complicated concepts for your epidemiological analysis. We do have a fair amount of time for questions, but I will start with those that have been given by our remote listeners. And I believe that the first one was trying to tackle this idea about the microenvironments. If you give me 2 seconds, I'm just going to track it back up and read it for you. So it says, the exposure data are collected in daytime hours, right? Capturing high exposures from many urban pollutants. But the residential locations are where people are spending their evenings and nighttime hours, right? So the whole idea of microenvironments. As an American, we often commute great distances to work, leading to large errors in exposure assessment of what exposures might be most linked to mortality outcome. So for your work, how do you expect this to play? Basically, is there any way, I believe this question is asking, that you can get to the exposure that is happening while commuting in all these kind of typical microenvironments that we don't usually have a way to address using linked data or administrative data? Right,
yeah. So yeah, it's one typical shortcoming of these types of studies are that we just have, we use residential address as the main only exposure address that we have, and assume that that's what they're, on average, what they're going to be exposed to for that year. Stats Canada is working on a data set that is looking at work locations as well as, I believe, commuting routes or typical commuting routes for a population, for a cohort. And so that will be possibly one of the analyses that we are looking at to address this potential bias in exposure misspecification. Other studies have shown that it doesn't seem like that type of misestimation doesn't seem to have that great of an effect, especially when you start taking it over multiple years and with a large population.
Thank you. There's another question. Ready?
Yes.
Okay, so hi from PHO in Toronto. So the Public Health Ontario then would like you to elaborate on your proposed work to just look at low-level exposures. Basically, is the idea that is your idea to only that you need real large N to assess these low levels, and will you have a large enough exposure contrast? Another question that follows: have you done any preliminary work on this using the existing data, which I think you started touching on, talking about what you plan to be submitting for publication at the end of the year? So yes.
Yeah, well, we hope to have a large enough population. So the 2001 can check, after exclusions and missing data, we have the sample size is about 2.5 million people, and followed for 10 years. And so you have a little bit of attrition due to mortality. And so what some of those results that we should do show that and some of the curves that we show are at lower dose levels. And then what we really hope to do with this end stacked analysis, so when we combine the 1991, the 96, and this 2001 CanCheck cohorts together, are really to get at, we should, with 10, so this will provide us with roughly 10 million subjects over a 20-year period. And what we really hope to get at is really just exclude people who have only lived in areas that are less than some threshold cutoff. So we'll look at less than 10 micrograms per cubic meter. We'll look at less than 7 or 5, and depending on our, depending on the power and the amount of people living in there, we hope to, see what those effects are at those certain cutoffs. The other thing, what another project that we hope to do, or I hope to do next year, is look at what happens when people move. So potentially you're trying to come up with a pseudo experiment. So when you look at, say, a group of people who lived in a low pollution area for 5 years, and then they all of a sudden moved to Toronto or downtown Vancouver or something like that, and live there, we'll see what their difference in the mortality association is versus people who always lived in the low pollution area versus, and then vice versa, look at people who only have lived in high for Canada, 10 or 12 parts per million, micrograms per cubic meter areas, and then compare them to people who moved from, say, the city to rural areas that are, say, have less air pollution. So then, so you have this natural experiment, the pseudo-natural experiment of people moving and tracking where they moved, kind of thing. So, we're really trying to hopefully torture the data enough and with large enough sample size to really get at this low dose response curve.
Thanks, Anders. There's one question from Dr. Ladva at Emory University. He is asking, how is ROS, or oxidative potential, being measured? He is interested in what components of air pollution would be driving that oxidative potential. In Atlanta, they've been seeing transition metals and a number of other things, but you likely have a different mixture across your cities. Mm-hmm. So what do you think?
Yeah, I'm not the best person to be asking this question. Scott Winchell, who is at McGill, he's the expert among this group doing the oxidative potential. From what I've gathered from when we meet up, sounds like it's the ozone and NO2 that seem to be driving that a little bit, but hopefully, or interaction between all three, but hopefully we will be using this oxidative potential outcome as a potential measure, which seems to be potentially more sensitive measure of actual exposure than an ambient concentration.
Yours? We do have a question here. Yeah.
Super cool. Thanks very much. I'm impressed by all of the different data linkages, and I'll chat with you later about all the income tax linkage. I'd like to know how that all happened. But anyway, I was intrigued by, there was a mention in some of your slides about looking at immigrants and new immigrants. I just wondered if you'd expand upon kind of, I guess, what's the research question there, that they're coming with a lower risk, and or I don't know. I'm just curious what the research questions are related to the immigrant.
Yeah, good question. Generally, when new immigrants come into Canada, because of the vetting process, they do, when you look at their health outcomes compared to Native Canadians or like Canadian residents, they have better health outcomes than Canadians. They also tend to move into cities as well. So we made a decision to exclude them for most of our analyses in order to, because it really is a completely different population that have different exposure profiles. And the other reason is we have no idea what their exposure profile looked like prior to moving to Canada. So given the time and the data, we do hope to do a sub-analysis and look at just recent immigrants, so within the 20 years of what we have our data for, and potentially see what do those risks look like, and are they greater, are they less, what do they change over time, kind of thing as well.
Okay, well, I have a question.
Okay.
It's about your certified analysis that you're presenting, so the paper that you have just published.
Yeah.
And I just wanted to get your explanation about why you see that relative risk being so increased when you stratify by airsheds. What's that?
Yeah, that was an interesting finding. What we believe is happening is whether or not that is, I can't quite remember whether it's the airshed itself or the population center size, where we're stratifying by those two different variables. What it seems to be is when you're just comparing, so what you end up doing when you stratify by these two regional variables is that you're comparing similar populations, and so you end up kind of, what we expect or suspect is that you're removing unmeasured risk factors or confounding that's potentially is happening within those areas. Other types of programs or green space, or and then for the airsheds, same thing, different types of weather patterns that may influence exposures. So that's what we think are happening. We want to probably assess that a little bit more and see what's occurring, because the same thing occurs. You can add a measure of population density as well as a measure of whether or not you live in a crowded city or not, and it seems to have a similar effect. But yeah.
We do have another question, Anders, here on the from one of our remote listeners. That's a question that is asking you, what are some reasonable correlations you draw in areas which experience annual wildfires? So Varun Sharma did mortality data. He's asking if mortality data differ in such regions from the cities.
Yeah, I'm not sure if I can answer that specifically. Some of these annual estimates might, over the years, reflect wildfires that occurred in an area for that year, and then averaged over the years. And then when you look at a 3-year lag or 7-year lag, it probably gets washed out, like that one high season probably gets washed out a little bit. So, this is more of an acute exposure versus a long-term chronic exposure. If you currently have recurring forest fires in an area, or if it's an area that you end up having lots of slash and burn piles, that might be a longer-term risk than a once in a while, like sporadic forest fire in the region. I should also mention that all those results that you were asking about earlier in the stratification, they were all stratified by age, 5-year age groups, and sex as well. So we're comparing, men and women different separately as well as within a 5-year age group.
Well, I think that this will conclude our presentation today. Thank you so much, Anders, for a really good talk. Good luck with all this data torturing that you're planning to do.
Mm-hmm.
And please join me in thanking Anders for his presentation.
Thank you.